Good morning. Welcome to the next in a series of oncology teaching videos for 2100 nurses. This is on non-Hodgkin's lymphomas, a very common disease that you've seen a lot of on 2100. First of all, the most common are B-cell types, although certainly we do see T-cell lymphomas. Basically, they're divided into the good, which are indolent lymphomas, like small lymphocytic, which is the lymphoma form of CLL, prolymphocytic lymphoma, lymphoplasmacytic, kind of a hairy cell, follicular marginal zone, and MALT lymphomas. The bad ones, like mantle cell and diffuse large cell lymphoma, and the ugly, like Burkitt's and lymphoblastic. Interestingly, this doesn't necessarily relate to cure rates, since the faster growing lymphomas are ultimately more curable, although when they relapse have a shorter survival. Now, the presentation of non-Hodgkin's lymphoma is very variable. It may be progressive nodal enlargement or abdominal pain and masses with splenomegaly, sometimes SVC syndrome. Patients can present with systemic symptoms such as weight loss, sweats, or fevers, or extranodal features such as bone pain or epidural spinal cord compression. The presenting symptoms often reflect the aggressiveness of the lymphoma, and low-grade indolent lymphomas often present with nodes in multiple areas with few symptoms. Aggressive lymphomas may present as a more localized mass or rapidly progressing masses with SVC, etc., often quite ill. The diagnosis is made by a lymph node biopsy, which is usually essential to the diagnosis. The minimum would be a core biopsy and certainly not a fine needle aspirate. Occasionally, a diagnosis is solely made on bone marrow biopsy, but is often difficult to completely define and categorize a lymphoma. The exception would be small lymphocytic lymphoma and W/WDLL, the lymphoma phase of CLL. Extranodal lymphomas obviously require biopsy of the site, and the diagnosis is based on microscopy, flow cytometry, and perhaps cytogenetics. Now, staging of lymphomas is fairly straightforward. There are stages 1 through 4, and then subtypes A and B. Basically, it relates to the distribution of the nodes. Stage 1 is one nodal or extranodal site. Stage 2 are multiple sites on one side of the diaphragm. 3 are sites on both sides of the diaphragm. And 4 is nodal plus extranodal disease. A relates to no symptoms, and B are the specific symptoms of night sweats, fevers, or weight loss of greater than 10% in the last 6 months. Now, the first thing we always do is stage the patient so we know how much disease they have. And staging is based upon physical examination, X-ray, CTs, bone marrow biopsies, PET, and flow cytometry on blood, marrow, or nodes. Now, the staging is interesting because low-grade indolent lymphomas often present at stage 3 or 4, which really reflects the slow growth of the tumor without bothering the patient, so they're sort of in symbiosis. Higher-grade lymphomas may be localized, or if widespread, are often associated with significant symptoms. We look at the IPI score for intermediate or high-grade lymphomas, International Prognostic Index, and a similar score called the FLIPI, or follicular lymphoma IPI, for the follicular lymphomas. And this relates to survival, treated, and overall potential outcome. Now, the IPI for intermediate and high-grade lymphomas relates to age, stage, LDH, performance status, and extranodal sites. And obviously for early stage disease, that eliminates the stage 3 and 4, and there's age adjusted for age less than 60. But the basic top 5 are how we rate it. The FLIPI is a little different since, remember, I told you that these often present with stage 3 and 4 disease. So now we're looking at numbers of nodal areas, LDH greater than normal, age over 60, stage 3 and 4, and hemoglobin less than 12. For 0 to 1 factor, the 10-year survival is 71%, but for 2 factors, 51%, and 3 or more factors, 36%. So one can see that the more disease you have, and especially the aggressiveness like LDH stage, and the low hemoglobins are related to survival. Now the treatment is important. The first issue we have to decide is whether to treat at all or watch. Low-grade indolent lymphomas can often be observed for long periods of time without treatment. However, intermediate and high-grade lymphomas need therapy, and the choice of therapy is based on evidence of long-term response or cure. Ironically, the good lymphomas are not generally curable, although treatable, and the bad and ugly are potentially curable. Treatment is either based on evidence of improved survival or a clinical trial looking for better therapy. And Rituxan is one of the mainstays of B-cell lymphomas that express CD20, which is the target of Rituxan. Low-grade lymphomas, stage 1 and occasionally stage 2, can be treated by radiation therapy alone, with about a 50% long-term survival. Higher stages of low-grade lymphomas require either Rituxan alone or Rituxan plus chemotherapy, and that's pretty standard. And certainly Rituxan has prolonged disease-free survival substantially. Intermediate-grade lymphomas are treated generally with R-CHOP, and this has been shown to improve survival in these patients when the Rituxan is added. And mantle cell and high-grade lymphomas are treated with aggressive regimens such as R-hyper-CVAD. But of course that depends upon the ability of the patient to tolerate that. Complications of therapy are very familiar to you and include febrile neutropenia, tumor lysis, bleeding from intestinal involvement, and specific chemotherapy complications such as neuropathy, hemorrhagic cystitis, nausea and vomiting, mucositis, and heart failure. And interestingly, the first cycle is the one with the highest risk when the patient has a big tumor burden and is sick already. We term responses in the following way. CR is a complete response. Now, there was a term called unconfirmed complete response, which referred to a 90% reduction in nodal masses with no growth. This actual terminology now has been eliminated in the most recent guidelines, which require a negative PET for a CR, and if the PET is still positive after treatment, it is not a CR. A PR is a greater than 50% decrease in the size of nodes or masses. Stable disease, less than a 25% decrease and less than 25% increase. And of course, PD is progressive disease. So you'll hear these terms being used for patients' courses. Treatment duration is classically 2 cycles past the best response or CR. As a practical issue, with generally 6 cycles for a rapid response, possibly 8 cycles for a slower response. With the use of PET and patients turning PET negative, we find that we often are treating for fewer cycles, such as 6 rather than 8, for a lot of lymphomas. The follow-up of the patient is pretty standard. The mainstay is history and physical examination. Routine scans past a CR do not add a lot to finding recurrent disease, and we usually scan if recurrence is suspected. Recurrent low-grade lymphomas are generally treated with more chemotherapy, Rituxan, or the radio-labeled antibodies such as Bexar or Zevalin. Recurrent intermediate or high-grade lymphomas may be treated with things such as R-ESHAP, R-DAC, R-MINT, etc., very aggressive regimens, and this is the place where we start to consider stem cell transplant, especially for younger patients. So again, I hope that you've learned something from this. As always, feel free to ask us if there are questions on the floor, and we hope you've enjoyed this part of the series.